Welcome to this segment. Once again, I'm Dr. Mumza Joseph. And with us today is a highly skilled specialist with us, Dr. Kyra Anthony.
Thank you for having me.
Dr. Kyra Anthony is a reproductive endocrinologist, Oxford trained, Oxford University in the UK. We are always glad to have you on these shows.
Thank you.
And as always, your insight is very highlighting to what we discuss.
Thank you.
So thank you. Today we shall be talking about assisted reproduction technologies. Why assisted reproduction technologies? Assisted reproduction has addressed a very big impact in terms of fertility treatments. It has enabled couples to achieve their fertility goals, couples who wouldn't otherwise have done so. With IVF, which is part of the reproductive technologies, we've had over 15 million babies born, and has also given families and couples what we call reproductive autonomy. People are able to plan when to have kids. People are able to plan their careers. It has saved us with preservation techniques, cancer. So it's a very important topic we are going to discuss today. And we are glad to have a very skilled reproductive endocrinologist with us. So basically highlighting what we are going to talk about, we shall look at what is ART in terms, in full, and what is its global impact, and then what are the recent advances in these assisted reproductive technologies. So starting from the top, Dr. Anthony.
Yes.
Briefly, take us through what is ART.
So ART, which is assisted reproductive technology, is a form of treatment for reproduction where the reproductive cells in the man, which are the sperms, and the reproductive cells in the woman, which is the egg, are joined outside the body. This naturally occurs within the body, in the fallopian tube or the tube of the lady. But because of one reason or the other, that hasn't been successful for this particular couple. So this treatment is an option to enable them to have a conception, because after they have joined the sperm, which is the reproductive cell of the man, and the egg, the embryo that is created is then transferred into the womb of the woman, and then it implants, and 9 months later you have a baby. So assisted reproductive technologies are anything where you have to handle eggs or sperm outside the body to give rise to a conception and then eventually a baby. So anything that hinders that naturally will be corrected by assisted reproductive technology.
Thank you very much, Doc. Maybe just take us through what are the different forms of ART.
The different forms of ART, we have what we normally do is IVF, in vitro fertilization, also called test tube baby, where we typically mix the eggs and the sperm outside the body, make an embryo, or we inject the sperm into the egg, we make an embryo, we implant it. Then there are cases where you can get the eggs and sperm and just put them in the fallopian tube, and the process continues from there. Or there are cases where after you've made the fertilization of the, that means the joining of the egg and the sperm, you put the early embryo, which is called a zygote, into the fallopian tube. But these technologies are no longer really practiced, because one of the most common indications for assisted reproduction is blocked tubes. And once you have blocked tubes, you cannot do a transfer of eggs and sperm into the fallopian tube, or a transfer of a zygote into the fallopian tube. So the main common technique being done is IVF or injection.
Injection, that's what we call the intracytoplasmic
sperm injection.
Thank you. Does egg and sperm donation fall under any of these?
Egg and sperm donation is an ancillary procedure or part. It's an accessory part. Ancillary, I would say, more of ancillary. It enables, for example, you have a couple, where either the man doesn't have sperm, then you get a sperm donor. So the sperm donor is more of like aiding
Okay.
what the process would be.
Okay.
And or maybe you have a couple where the lady has a very low ovarian reserve, then she gets an egg donor.
Okay.
So the egg donor in a way is aiding
Okay.
in part of the process of assisted reproduction for this couple.
Okay. Thank you very much, Dr. Anthony. Quite insightful. So we are talking about ART. Briefly take us through, why is it so important?
So before 1978, when the first IVF baby was born, that is Louise Brown,
Yes.
having blocked tubes that could not be repaired by surgery meant that you are going to be barren.
Okay.
Being older than 40 years or with a low ovarian reserve or in menopause, you're considered barren.
Okay.
Being born without tubes, barren. Being born with no uterus, barren. Being born with no ovaries, barren.
Okay.
Having low sperm count that cannot be corrected by supplements or you cannot do an insemination, also
Barren.
sterile.
Yeah.
So those words were quite common in the 70s. And to make a comparison, I'm very sure, even here in Uganda,
Yes.
10 years ago, the words omugumba, barren,
Yes.
sterile were quite common. But I can dare anyone to tell me that they have recently had someone call someone barren or had someone identifying themselves as barren. It's now like a thing of the past.
Yes.
It's so, with IVF or assisted reproduction, childlessness is something that can be solved. There is a solution for everyone. Even in the most complex of cases, there is a solution for every couple. Yes.
That's how ART has simplified it.
Yes.
Please share with us a brief success story with us.
So recently, just as of, I had to give out a pregnancy test results that would be on Tuesday.
Okay.
So this particular story really caught my mind. So this is a lady who has been, unfortunately, she lost her uterus. When she was giving birth to her first child, she had significant bleeding and the uterus was removed. And at first, they tell you, this is it for you. And so she initially had some challenges in her marriage. She actually lost her marriage because of that.
Yes.
And then got a new relationship. But her desire to have a child was really quite strong. And so when she came to me and told me she needed to use surrogacy, and the reason was because she didn't have a uterus and she needed to have a child. That was a very touching story, especially how through giving birth, she actually lost the chance to have another child.
Yes.
And I was very happy for her because with her eggs and the sperm of her partner, we were able to get a surrogate pregnant. And we actually did the delivery on Tuesday. And she's with her baby right now, very happy. And like a miracle to her, a dream come true. Just like I said, there's a solution for everyone. So with the availability of surrogacy, being able to grow someone's embryo in a different person for 9 months, that is how far the technology has actually gone.
Okay.
To the point that even if you have no uterus, you can actually have surrogacy done and have a child. And that child is yours.
Perfect. That's quite touching. So, I mean, since the first IVF baby, Louise Brown, IVF has progressively advanced.
Yes.
We are looking at things like pre-implantation test, genetic testing. Briefly, take us through it.
So PGT, or pre-implantation genetic testing, is where we do a biopsy.
Okay.
A biopsy is like sampling. So we do the IVF, we create embryos outside the body, and we sample each of those embryos to see, to check for genetics,
Yes.
who's a girl, who's a boy. And in the scenario where we have a genetic disease, like sickle cell disease, cystic fibrosis, Huntington's chorea, all these diseases that seem to be caused by a substitution or a deletion, or something, one gene is messed up somewhere, and then you get the disease. So through checking or sampling these embryos, we can identify these diseases. And then we transfer the embryo that does not have the disease. Even transferring the embryo that doesn't carry the risk of having the disease, if they met a partner, who had the disease, or a person who's a carrier.
Okay.
With pre-implantation genetic testing, there's a chance that sickle cell can be eradicated in the next generation, if only it was accessible. Because if everyone who had sickle cell or a carrier was going to do pre-implantation genetic testing, and all embryos transferred would not have sickle cell disease or sickle cell gene, you would literally have a generation without sickle cell, if only it was accessible. Unfortunately, it's not that accessible because of cost. But that is pre-implantation genetic testing in a nutshell.
Wow.
Yes.
So, pre-implantation genetic testing, it seems to have advanced to the extent where there is also mitochondrial change. As in, does it interfere with the natural process of natural selection? You're selecting the babies you want?
That is true. But the good thing with the pre-implantation genetic testing is that we're trying not to transfer a gene that would rather cause a disease in an offspring.
Okay.
And that is kind of beneficial in a way, because we know that people who have sickle cell disease really do suffer.
Okay.
And no parent, if they had a chance to have a child without sickle cell disease, they would literally take it.
Okay.
And so the next thing is, what you're talking about is mitochondrial transfer.
Yes.
So there are these diseases that are a result of mitochondrial disease. So mitochondria is like the energy powerhouse of the cell.
Yes.
The part of your cell. So if you look at a cell like a house, so where the kitchen is, where food is made and served, that is where the mitochondria would be.
Okay.
It literally gets your food, processes it
Yes.
to give you energy so that the cell can get the job done. Some genetic diseases affect the mitochondria and make it difficult for cells where the diseased mitochondria are to function normally. So you can have issues with muscle. Eyesight, brain function.
Things like cystic fibrosis.
Yes. Things in the body that use a lot of energy. And the only problem is that you inherit all your mitochondria from your mom. So what the man provides in reproduction is only the DNA in the sperm. Everything else that we make, our hair, our eyes, whatever, all that material is within
the mother.
Yeah. And so the mother provides all the mitochondria that will divide to make up all the mitochondria in all the cells in your body. So if my mother has a disease with the mitochondria, her offspring will have the disease in mitochondria. So what mitochondrial transfer does is that they get an egg, which is normal. They remove the nucleus. The nucleus is what's the DNA material.
Yes.
Or the genetic material within that egg is removed. And then they get the genetic material from the person who has mitochondrial disease.
Yes.
And put it in that egg.
Yes.
In a way, that egg has two people. The mitochondria of someone who was healthy, the donor,
yes,
and the DNA or genetic material of the person who has the disease.
Yes.
And then that is fertilized to make an embryo. So the thing is that in this scenario, you have three people giving rise to an offspring. So who is the parent? Genetic parent, mitochondrial parent, or it's quite interesting.
Genetic parent.
Almost three people are involved in making such an offspring.
Yeah.
But that has gone a long way, because with mitochondrial disease, even if you did IVF, you would still have it.
Yeah.
But with mitochondrial transfer,
it changes the story.
Let's change the story.
Thank you so much, Doc. So, IVF, as we know, its success is limited worldwide. It's not 100%. We know that endometrial receptivity plays a very big role.
True.
Recent advances have tried to improve that. How helpful?
So, of course, I'll talk about the advance, then I'll critique it.
Yes.
We believe that there's what they call a window of implantation, the ultimate opportune time when you're most likely to have an implantation.
Yes.
Consider it this way, as people say, safe period or unsafe. Okay, the fertile window, as they call it, that ovulation may have occurred 2 days before or 2 days after. So if you have sex during this time, you'll likely get a pregnancy. Yes. So even with implantation, there is a window where the womb is most likely to accept. Because implantation is about the embryo communicating with the womb, and the language is the same. The moment the language is not the same, there's no translator in the womb. It is just cancellation. So there was a belief that people who have recurrent failures with IVF, may have a problem with that communication. That we are putting the embryo back in at the wrong time when the womb is not ready. So the communication is kind of jumbled and it doesn't work. So what this treatment does is that they test the womb in a mock cycle. Mock meaning a trial.
Mock transfer, yes.
And they check to see if the lining of the womb is receptive and when it is receptive. When they figure out that time, then we do a real cycle and they implant at that time. But the results have been kind of mixed.
Yes.
Yeah, some get, some don't get. At the end of the day, the technology is really trying to get better.
Yes.
It's not yet really at the optimal part. But I believe there's significant promise because the science is legit. The question is, are we looking at the right signals for appropriate optimal communication? Do we know them? Or that's where the mistake is. Maybe we don't know as much as we think we do.
Endometrial receptivity is very, very hard to track.
Yeah.
Very, very hard to track. Well, ART has also helped us in terms of gamete preservation. We've moved even to ovarian tissue preservation, testicular tissue preservation. How important is this?
So I am biased. I'm a person who's an expert and also an advocate for fertility preservation in cancer patients, especially children, adolescents, and young adults.
Yes.
So the viewer out there may not know this, but actually cancer treatment can have an impact on future fertility.
Yes.
And this is known worldwide. But there are options to preserve the fertility before you have the cancer treatment, which you need to have discussed with your clinician. Very, very important. So the only challenge was before we started to freeze ovaries, we had only one option. You had to be old enough to go through stimulation of the ovaries so that the eggs can be collected and stored. But we have adolescents and children who cannot go through stimulation.
Yes, definitely.
So with ovarian tissue freezing, we are able to go in, pick a piece of the ovary or the whole ovary, section it,
Yes.
and put it on ice. And when you're old enough, maybe we did it when you were 12 or 10 or 9 or 3, when you're old enough, 20, 25, we put back the ovary.
Yes.
And the ovary functions normally. Your periods resume in case you had some kind of pause in your periods. People actually go on to conceive naturally after ovarian tissue transplant. So that's how far we've gone, that we can pause, keep an whole ovary, return it, and rescue someone from menopause because of having undergone chemotherapy. The same thing happens with the testicles for the boys. As you know, until after 13 years of puberty, you cannot produce semen.
Yes.
And so if you're to do preservation below 13 years or before puberty, where you can't have semen to freeze the sperm, then the alternative is to go in, remove the testis, dissect, put it on ice. And when the child is ready, put the testicular tissue back.
Yeah.
And then sperm production resumes. For this kind of technology, we have not yet had human trials because the first cohort of boys whose testicular tissue was preserved is still very young.
Very young, yeah.
But we've had a lot of success
Yes.
in other animals like monkeys, where we've been injecting sperms that were tissues that produce sperm, testicular tissue. It was frozen back into the testis.
Yes.
And then these monkeys go on to produce children naturally without any assistance. So from those models in animals, the science is sound, it's legit. We hope that when this cohort reaches of age and they have their first transplants, it will be successful. It will be a real big game changer. Yes.
The world is evolving, and ART is actually also evolving compared to where we started from.
Yes.
So the other thing is, we've seen elderly couples, 50 years, 40 years, people with premature ovarian failure, even young ladies. I mean, you check their AMH and it's pretty low. Is that the end of their story? We've had things like ovarian rejuvenation. What is its role?
Okay. So there's this, of course I have to put up a disclaimer. I don't believe in ovarian rejuvenation. Okay, the biology is that the science behind ovarian rejuvenation is that there is a quiescent or silent, dormant germ cells in the ovary,
Yes.
which can be awakened. And that with the right environment,
Yes.
microenvironment, these germ cells will awaken and progress and become, eggs and eventually lead to a birth. And because that's usually much in conflict with the story, which we all know that during the life of a woman, when she's in her mother's womb, she will make all the eggs
That she
that
has.
she will need.
Yeah.
After that period of time, which is about 5 to 6 months within your mother's womb, you can't create any more eggs.
Yeah.
So the fact that there are some silent germ cells that are dormant, waiting, it's a bit hard to prove. Maybe these patients who are benefiting from ovarian rejuvenation have something else that has occurred
Yes.
that is then corrected by these procedures. That is not necessarily premature ovarian insufficiency.
Yes.
That needs to be investigated. I believe that the jury is still out for ovarian rejuvenation. A lot of work still needs to be done.
Yeah.
A lot of studies need to be published, and the science needs to be well understood. I will not make a comment to either advise people to have it or not to
Or
have
not
it.
have it.
For now, the science still stands. Once your blood levels show that you have ovarian reserve depletion, there are options. Donor egg.
Donor eggs.
That is a better chance at having a child. But this experimental therapy, you may go around it, spend money. I've met so many patients who have spent a lot of money. And, they're not happy. I guess, if you're a clinician out there and you're offering this, just be honest and tell them where the science lies. And let them make a decision. Because there's something else that actually works.
Okay. Sometimes the decision also to donor eggs is not so easy to make.
I think then we need to do better as clinicians in counseling our patients. Sometimes a hard decision is the only decision that you have. And it's up to us clinicians to acknowledge that.
That this is it.
And then talk to you about it. Sometimes even the decision of a donor egg, the conflict is within me, the clinician, myself.
Yes.
I cannot accept it.
Yeah.
So I project that onto the patient, the fear that I have on my own.
Yeah.
But I think if the patients got to know the facts, they would really make an informed decision. Yeah.
Definitely. Thank you so much, Dr. Anthony. Quite a highlighting session. I hope the viewers are benefiting. So basically recapping and summarizing what we've talked about. IVF, ART with all its advances, it's still a costly adventure. Not everyone can afford it. I mean, we've said it's choice. Now everyone can have a child.
But the limiting factor is cost.
Is cost.
And all these add-ons have an additional cost.
Additional cost, yes. So any strides
towards that?
Yes.
All I can, of course, now this is speaking in the future.
Yeah.
So there's something called DNA, like the DNA of a person. So there was a project called the Human Genome Project in the early 1990s. It was the first project which the whole world engaged in to map out the whole genetic code of the human body, the human species.
Yes.
That's how we know this gene, that gene, that gene, that gene. At the time in 1993, to do one genetic sequencing, you needed $1 million US. You needed $1 million US. Today, to do one whole genome sequence, you need $1,000 US. Unfortunately, the most affordable cost for IVF may not be in the current generation. As you can see, $1 million in 1993 to $1,000 in 2024. But I know that as the technology advances, there are people who can produce these consumables. the cost of production of consumables. You know, it keeps on reducing. The technology gets better and better, and costs get reduced. I can allude to the viewer to what's currently happening in the aerospace exploration, where I think a gentleman called Elon Musk is trying to use reusable rockets to cut down the cost of going back into space. We last went to the moon 50 years ago. So the technology is moving, and I know that maybe 10, 20 years, 25, 30 years from now, IVF might just be affordable.
Okay.
But not now.
Not
and
now.
there's nothing that I can do about it.
Definitely.
Yes.
Quite an expensive procedure. And then, like we said, its success is not guaranteed.
True.
What's your message to someone who has had an unsuccessful IVF cycle?
To the viewer out there who has had a recent unsuccessful IVF, don't give up hope. The science is that with every repeat IVF, your chances increase. So many out there didn't have the first one positive, but the second one was positive, or the third was positive. One thing I know is that everyone eventually gets pregnant.
Yeah.
I have this thing I believe in my mind when I'm seeing patients. I tell them, I discharge everyone. I don't have a patient who has been seeing me for years.
And
Every time I see you on the third one, I am bothered.
yes.
What different thing can I do for you? And I can tell you, even the cases that we thought would never yield have yielded. So I believe that hope cannot be lost. There's a pregnancy for you out there. Don't lose hope.
Definitely.
And above all things, doctors are not gods. They only offer a little human help.
Yes.
God is the real giver of life. Thank you.
So, I mean, the stories are quite interesting. Recently, I had an elderly couple. The lady was 47 years. The man was 52. A sexual dysfunction, erectile dysfunction. So we couldn't even get a sperm sample through ejaculation. Woman, diminished ovarian reserve, massive uterine fibroids, with a prior pelvic fracture. She wanted to carry her own baby. Yeah. So we had to first deal with the fibroids. The womb was not really good. Removed the fibroids, gave her a year of rest. Came back. We cancelled her, definitely. Donor gametes, at least for the eggs. Did test, got some sperm from the man. And she succeeded on the first transfer.
Perfect.
Carried her pregnancy to term.
That's good.
I delivered this lady, but I couldn't help it. The emotion was just too much.
I know.
Her holding the baby, it was too much. So it's just unbelievable how ART can change stories.
True.
Yeah, and it's not just one story.
Several.
So many people out there have stories. It's different for everyone.
That's true.
Some have succeeded after the 7th trial. Others have succeeded on the first.
That's true.
But like you said, everyone should be discharged with a baby.
Yes.
Yeah. Thank you so much, Dr. Anthony. Your concluding remarks, please, to the viewers.
IVF is here, and it has changed lives. For those out there who are having challenges having children, make sure 2025 you have an evaluation to find out where the problem might be. And if the doctor does suggest an IVF, don't be scared. The treatment is feasible. It actually works. Plan for it. Have it. And I wish everyone a fruitful, reproductive 2025.
Thank you. Viewers, Dr. Anthony, like I said, is a reproductive endocrinologist. He sits at Life Shore Fertility Center, Mawanda Road. As you can hear his insights, he's Oxford trained. very highly skilled. So, in case you want to reach him, feel free to contact us through this platform. Otherwise, we wish everyone a Merry Christmas. Those ones who are hoping for a child in 2025, we hope your dreams come true. Thank you very much.